Chapter 10. The Metrics of Fear. Like dreams, statistics are a form of wish fulfillment. Jean Baudrillard. Logic is slow and fear is fast. Understanding numbers requires logic and sound reasoning. Politicians and the media very often use fear to circumvent our logic, because it slows our thinking. We can be dazzled and alarmed by a big number, or a steep line on a graph, and then we're less likely to question the nuance and more likely to be suggestible. From the beginning of the epidemic, the government and media reported the daily death tolls with a macabre dedication and, as I have said before, without context, such as comparisons with deaths from other causes, or total deaths, or recovery figures. Humans can't sustain fear indefinitely. We get bored, we relax, or, some might say, we become complacent. COVID didn't impact our lives in the ways the Chinese social media videos promised. People didn't fall over in the streets, to be instantly surrounded by medics in hazmat suits. The weight of rational evidence and experience could have started to outweigh fearful imaginings, and then people's sense of personal threat, as SPIB put it, might have relaxed. How was the government to sustain the belief in the necessity of restrictions to our lives over the months? One method seemingly favored by the government was the choice of metrics. Daily death tolls dominated government press briefings and media reports until they stopped surging, and were perhaps too low to report, or didn't seem newsworthy. At that point the focus switched to the reproduction number, R, and then cases. However, hovering just above or below 1, the R is not a very attention-grabbing number, whereas cases have seized headlines, because the absolute totals are large. I spoke to David Patton, Professor of Industrial Economics at Nottingham University, who has taken a keen interest in the reporting of data during the epidemic. One of his worst data moments came in mid-April 2020 when, it was clear deaths were going down, but Chris Whitty, the chief medical officer, said we hadn't seen the peak yet. That was a big one for me. He was downplaying the downward trend in deaths. I think there were obviously deliberate policy decisions to make people take it seriously, but the data should be presented factually and then interpreted. Fear is a depreciating asset and we found ourselves in a time of short selling. Cases which don't translate into deaths can't sustain the fear, which is perhaps why Chris Whitty and Patrick Valance delivered a shock and awe presentation on the 21st of September 2020 about cases and hospitalisations. Metrics selected for maximum impact gave way to fantasy. A red chunk of predicted but not predicted cases loomed like a child's red crayon drawing of a monster, the mythical monster a rather bad parent might scare their children with if they don't behave. Apparently, their decision to present 50,000 cases by mid-October as a possibility was taken carefully, but it was widely suspected that the decision was made because the bigger the number, the greater the fear, and the more compliant the adherence by the population. The anonymous scientist who works within Whitehall told me, "You can't do a pandemic without honesty and trust, but the problem is people don't trust the government anymore." The Whitty and Valance press briefing was the ultimate psyop. Even really intelligent people had so much cortisol flooding through them that they couldn't think rationally. I know people who believed the fantasy graph. Now they're sold on more lockdown. While death tolls and cases dominated the headlines, other metrics were quieter casualties. Discussion of all impacted metrics is essential for people to make cost-benefit analyses. Yet COVID deaths were not balanced against unemployment, the lengthening NHS waiting list, missed cancer screenings, national debt, business closures, or calls to suicide helplines. As Patton told me, there is a lack of critical thinking about parallels. We don't say no one is allowed to drive a car to prevent all road traffic accidents. We can have different value judgments, but it's not unhealthy or wrong to discuss trade-offs and take a cost-benefit approach. What is the result of all this fear-mongering? The messaging that was initially designed to help us stay safe by scaring us has been so effective that Britain quickly became the most frightened nation in Europe. People significantly overestimated the spread and fatality rate of the disease. The British public thought 6 to 7% of people had died from coronavirus, around 100 times the actual death rate based on official figures. I tested this out on a neighbour and asked her what percentage of the British people had died. She said 10%. That would have been a very noticeable 6.6 million corpses. Did using the metrics of fear work? Did it create more compliance in the British public? Whether you think people followed the rules or not will depend on your own experience and attitudes. I asked a dear friend if he and his partner had been compliant. He told me that they had followed the rules very strictly to start with, and they had always followed them in general. It transpired they had had people over to their house, but only a couple at a time and only for drinks, not for dinner, so that was all right in their eyes. Of course, for a long time people couldn't enjoy a drink in a pub without ordering a substantial meal, so, although he had the best intentions, my friend was negligent in omitting the life-saving food. I expect most people followed the rules, but they broke them in small ways when it suited them. One study in September set out to investigate adherence to test, trace and isolate, as it was considered one of the cornerstones of the recovery strategy. It found that only 18% of people self-isolated after developing symptoms and only 11% quarantined after being contacted by test and trace. People's reported behavior fell short of their intended behavior, but this seems a very unsurprising insight into human nature. The government and media whipped people into a sustained and at times hysterical fear. Then frightened people voted for harder lockdown measures in public opinion polls. Government then obliged the people with more restrictions. The restrictions didn't allow the fear to subside, then people voted for more restrictions, and so on in a self-perpetuating doom loop. Public health policy became a sick dog chasing its own tail. There is another reason that the government focused on particular metrics during the epidemic. Key performance indicators, KPIs, are to civil servants what the Ten Commandments were to Moses. KPIs enshrine the work of all professionals in a department towards improving those goals and evidencing how they are doing so. For COVID, the KPIs were cases, positive PCR test results, hospitalisations and deaths. Once established, the KPIs would have superseded the metrics for the economy, or other aspects of public health, or anything else. Staggeringly, the Treasury revealed it did not forecast the economic impact of the second lockdown. The clearer and more easily measurable the KPI, the more powerful it is in rallying activity and obscuring contexts outside the KPI. These KPIs overtly act to blind the government and all civil society to anything else, and then effectively confuse journalists and the public, which in turn creates more fear. The COVID KPIs sit like greedy little gods on thrones made of skulls, demanding obsequious worship. It gets worse. The COVID KPIs are not reported as they are actually defined. I noticed throughout 2020 that journalists, doctors and politicians would misuse them. For instance, patients admitted actually includes people admitted to hospital who tested positive for COVID-19 in the 14 days prior to admission, and those who tested positive in hospital after admission. Inpatients diagnosed with COVID-19 after admission are reported as being admitted on the day prior to their diagnosis. So, patients admitted with COVID aren't just patients admitted with COVID, which is what anyone would assume unless they have read the small print. They are also patients who were admitted for something completely different, but tested positive routinely for COVID, as well as patients who were infected with COVID while in hospital. The overall total will be a useful measure when planning how to manage wards and healthcare, but as a public-facing metric it is misleading, and as a KPI it cannot solely respond to restrictions designed to reduce community transmission, when it is also driven by nosocomial infection. Similarly, deaths were frequently reported using the figure that the UK government dashboard pushes to the top, death by date reported. Due to time lags in death registration, those figures could be lumpy, subject to sharp ups and downs. There was always a dip on a Monday, after weekend delays, and then a higher figure on a Tuesday. On a day with a big number you could guarantee certain MPs and journalists would grimly tell us that X people died today, when in fact they didn't die today, they died at some point over the recent days and weeks. On the 30th of December there were 981 deaths by date reported. This figure was bandied around the media and social media, with the incorrect interpretation that the people had died that day. However, the figure included a lag of death registrations over Christmas. In fact 588 people died on the 30th of December, which was not confirmed until the 6th of January. That total will continue to rise over time as late death registrations are added. These people all died, so it doesn't matter how and when the deaths are reported. Am I splitting hairs? Lumpy data produces hotspot days, creating panic and driving, or maybe justifying policy decisions. And maybe that is the plan. After all, the low days were not reported the same way. The government's cost-benefit analysis of lockdown published on the 30th of November didn't include the use of QALY's quality-adjusted life years. This was a strange omission, as they are the bread and butter metric of the NHS. The average age of death with COVID is 82.3 years, 1 year more than the average life expectancy in Britain. The NHS normally allows up to £30,000 for each QALY that a treatment could save. Depending on how many QALYs lockdown saved, the cost is £96,000 to £1.97 million per QALY according to a report by Civitas. 7, and that's quite generous because it might be that lockdown saved no lives at all. The precautionary principle behind lockdown has been ideological and may be proven, in the end, to be more harmful than doing nothing, because the cost-benefit analysis didn't contain the numbers. Here are some examples of the dodgy data and mendacious metrics wielded during the COVID epidemic. The Imperial College model. Neil Ferguson's Imperial model predicted that there would be over 500,000 deaths in the UK and 2.2 million deaths in the US if there were no measures to suppress the virus. Described in an article in The Telegraph as the most devastating software mistake of all time, the modelling used outdated code. However, that insight was not gained easily. At a time when there had probably never been such a need for scrutiny, there was remarkably little. The paper by Imperial was not peer-reviewed and calls by scientists to inspect the code were ignored for weeks. When the code was released, it was not the original, but had been modified by teams from Microsoft and GitHub. The delay was unacceptable given the level of public importance and interest. The doom-laden modeling grabbed headlines around the world and is credited with some of the responsibility for shifting policies on lockdown. Aside from the dismal coding, was it robust? Models based on assumptions in the absence of data can be over-speculative and open to over-interpretation. Professor John Ioannidis of Stanford University issued a strong warning to disease modelers to recognize the severe deficiencies in reliable data about COVID-19, including assumptions about its transmission and its essentially unknown fatality rates. For instance, the model assumed no existing immunity to COVID. Since then, 6 studies have shown T-cell reactivity, which gives protection from previous coronaviruses in 20% to 50% of people with no known exposure to COVID. In 2000, Ferguson predicted there would be up to 136,000 cases of Creutzfeldt-Jakob disease in the UK. In fact, there were 178 over 20 years. In 2001, Ferguson's modelling led to the policy of contagious culling healthy animals on neighbouring farms, which led to 6.5 million cattle, sheep and pigs being slaughtered, economically devastating Britain's farmers. A report entitled Use and Abuse of Mathematical Models, an illustration from the 2001 foot and mouth disease epidemic in the United Kingdom, strongly concluded that the slaughter that took place was grossly excessive, and that the rift between the models and the practical reality of implementation may be so huge as to make the models irrelevant. In 2005, Ferguson said that up to 200 million people could die worldwide from bird flu. They didn't. MP Esther McVeigh neatly argued that the imperial modelling should not be considered infallible by pointing out that 2,700 prisoners were predicted to catch COVID and die, yet only 47 did. As she said in January 2021, there is no better example of the scaremongering to drive government policy they wanted to see from the so-called experts than the predictions on prisoner deaths. I appreciate that these estimates aren't an exact science, but the difference between a prediction of 2,700 to the reality of 47 is embarrassing to say the least. At the time of publication, the modelers on SPIM have predicted a pessimistic but plausible third wave in the summer of 2021, resulting in a further 59,000 deaths. Models are only as good as their ingested data, and this model reportedly underestimated vaccine efficacy, herd immunity, and did not allow for the seasonality of a respiratory virus. So, what is the point? Model reliability doesn't seem to need to be proven. There are no penalties for being overcautious and getting it wildly wrong. And despite his track record, Ferguson et al. Are still producing models for the UK government, terrifying people and unleashing dire consequences on the way. Public Health England death data. Under Public Health England's original system, a COVID death was anyone who tested positive for COVID and then died of anything at any time. So, if someone was run over by a bus, their death would be counted as a COVID death if they had tested positive for COVID at any point in the past. No further explanation is needed about how wrong that is, and how it would inflate the death figures. The team at the Oxford Centre for Evidence-Based Medicine pointed out the anomaly, and Matt Hancock, the Health Secretary, ordered an inquiry. Dangerously poor quality data from Public Health England was misleading the government. Were Public Health England innocent of such a misleading mistake? The new system counted deaths within 28 days of a positive COVID-19 test. This would still include people who died from other causes. Not all of these deaths were from COVID either, but it was an improvement and resulted in the immediate removal of 4,149 deaths from the 15th of July death count. As David Patten said, the metrics always seem to err on the side of maximizing numbers, and it takes time to undo that, like with the Public Health England death counting. The BBC continued to report FA death data even though the government had officially suspended it, so that had the effect of people thinking deaths were higher than they were. There is also a case for saying we don't report daily cases and deaths for flu, so just reporting by day is damaging in itself. And on a stronger note, the anonymous scientist who advises at Whitehall told me, the higher the death toll, the more draconian the measures you can bring in. The plan would be to go with the big numbers and then say there was a problem with the figures. The BMA and Masks. Some data has crumbled like icing sugar at the merest whiff of a challenge. Sadiq Khan quoted some quite astonishing figures, that someone not wearing a face covering had a 70% risk of transmitting the virus, but by wearing a mask the risk was reduced to 5%, dropping to 1.5% if both parties were wearing masks. The source was the British Medical Association, BMA. I contacted the BMA, which claimed that their Medical Academic Staff Committee and Public Health Medicine Committee had produced the calculations. 7 emails, 2 tweets and 1 phone call later, it turned out these figures had not been calculated by the BMA, but were based on a presentation by Chinese infectious disease specialist Professor Wenheng Xhang in March. The BMA withdrew its claims, but by then the figures had been published on national broadcast and print media and in Twitter memes shared by Sadiq Khan, and are all still in circulation now. Associated Press Fact Check came to the same conclusion as me and labeled the claims partially false. The strange thing is that memes were circulating in other languages at around the same time and earlier, making BMA's claim to have produced the calculations even more spurious. The effort to counter misinformation online has certainly seemed one-sided. Hospitalisations. Sir Simon Stevens, the chief executive of the NHS, said on 29 December 2020 that 20,426 people were being treated for COVID in hospitals in England, which was higher than the previous peak of about 19,000 in April. Comparing two absolute numbers was problematic. During the winter we always have more patients than we do in April. Numerically there were more patients in December, but just presenting that as a crude statistic is disingenuous because we also had more beds nationally overall than we did in April, and without the occupancy figures as a percentage it's impossible for anyone to understand what the inpatient numbers mean. Further breaking down occupancy into overall total, ICU, beds with oxygen and mechanical ventilation beds for COVID and non-COVID would provide more insight. In April 2020, all the COVID patients were there because they were truly ill with COVID. Later, we were routinely testing people in hospitals regardless of why they were admitted, which was a sensible measure for infectious control, but meant some people were classed as COVID patients in the government dashboard figures but were actually in hospital for different reasons. The absolute number of 20,426 includes those admitted with COVID and diagnosed with COVID in a hospital setting. So, what was the total split by people who go into hospital because they had COVID, nosocomial infections, acquired in hospital, and those who were routinely tested when they were in for something else and had a positive test result? Answers to those questions would have revealed how much of a problem community versus nosocomial infection was and helped guide decisions about the value of restricting liberties in the community. An NHS England data scientist who must remain nameless for the sake of their job, shared some confidential information with me. We looked at the data for the southeastern London when I was writing to my MP about the tier restrictions at the time. At that point my MP told me that local hospitals were overwhelmed with COVID admissions. In fact, in mid-December in the southeastern London only 20% of the total hospital admissions were patients actually admitted with COVID. About 25% of hospital admissions had caught COVID in hospital. And the remaining 55% had been tested while in for another matter and found to be positive. By January 2021 the government had admitted, albeit in a very low-key no fanfare way, that test results could be positive long after someone is infectious. which means that of those 55%, an unspecified but significant number will be false positives. All this paints a different picture. In addition, approximately 30% of the most recent admissions were from care homes, therefore also nosocomial infections, as they were acquired in a care setting. Another important consideration is staffing levels. Talking about absolute numbers of inpatients requires the context of occupancy percentages and also staff available to look after them. A responsible government and NHS would be providing this context. The use of absolutes was not untruthful, but it obscured more important facts. It seemed like a false flag, designed to create alarm and therefore soften us up for the next tranche of emergency restrictions. A BBC article reporting on Stevens's statement only gave a modicum of context and led straight into a scientist's call for more lockdown, in what had become a familiar government media lockstep. The use of alarmist data is, well, alarmist, and the elision of detailed data is suspicious. Combined, this erodes trust in leaders and the media. I emailed NHS England's media team with a request for all of this data. I followed up with emails, phone conversations and tweets. I did not receive the data. By March 2021, COVID hospitalisations were at the same levels as October 2020. Strangely, Simon Stevens did not provide an update to the nation. As usual, numbers were used to scare, but not to reassure. The Whitty and Valance shock and awe presentation. Chief Medical Officer Chris Whitty and Chief Scientific Advisor Sir Patrick Vallance warned on 21 September that there could be 4,000 COVID deaths per day in the autumn. Nothing like that total was ever reached. The Valance chart showed infections hitting 50,000 cases a day by 13 October without action. When this day arrived, the moving average was 16,228. Former Prime Minister Theresa May criticised the government's approach, remarking that for many people it looks as though the figures are being chosen to support the policy, rather than the policy being based on the figures. Even The Guardian, which in general took a pro-lockdown approach during the epidemic, commented that the data was selective, determined to cause alarm. In a highly unusual move, the UK Statistics Authority also voiced concerns that the graphs presented to the public were out of date and overestimated deaths. The second wave. Public Health England said that more people died in the second wave, compared to the first wave of the epidemic. Yet according to the continuous mortality investigation, set up by the Institute and Faculty of Actuaries, there were 72,900 excess deaths from March to the end of December. 60,800 of those occurred in the first wave, but just 12,100 in the second. It means that, unlike the first wave, huge numbers of people included in the coronavirus death figures would have been expected to die of other causes in those final few months of the year. It seems unlikely, impossible even, that Public Health England would not know this. The most deadly infectious disease in a century. To mark the anniversary of a year of restrictions, the ONS produced a report which declared COVID-19 to be the most deadly infectious disease to hit Britain for over a century. Naturally, this led to lurid doom-laden newspaper headlines such as "Coronavirus is the deadliest pandemic to hit Britain since the Spanish flu in 1918 and has caused the worst recession in 300 years, but house prices kept going up. COVID-19 most deadly infectious disease in UK in 100 years and devastating UK COVID data lays bare impact of virus on lives, jobs and society in 2020. But according COVID, the accolade of causing more deaths in 2020 than other infectious diseases caused for over a century, was only possible with a disorientating twisting of truths. The ONS categorized COVID as an infectious and parasitic disease, putting it in a different category to other respiratory diseases including influenza. In this surprising category, COVID wasn't even keeping company with sepsis, as David Livermore, professor of medical microbiology at the University of East Anglia, wrote for the Lockdown Skeptics website. As he pointed out, the ONS's graph wildly underestimates infection deaths such as for bacterial sepsis and flu, which falsely elevated the deadliness of COVID. Lockdown Skeptics asked, what was the ONS thinking producing such a misleading graph and report, knowing full well it would grab lurid headlines and feed the hysteria that has characterized the last 12 months. This was a disheartening report from the ONS, but it was at least in keeping with marking a year of the metrics of fear. The PCR test. We have a simple message for all countries: test, 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 said Dr. Tedros Adhanom Ghebreyesus, Director General of the World Health Organization, on 16 March 2020. How would countries test? Using the PCR, polymerase chain reaction, test. On 14 December 2020, the WHO issued an information notice for IVD users, to ensure users of certain nucleic acid testing technologies are aware of certain aspects of the instructions for use for all products. As many doctors and scientists had pointed out, the PCR test can produce false positives as well as false negatives. One problem is that when run at a high cycle threshold, CORT, the test can create a false positive, or pick up that someone had an infection weeks earlier. It is not a definitive test of infection or infectiousness. As the notice says, when specimens return a high CORT value, it means that many cycles were required to detect virus. In some circumstances, the distinction between background noise and actual presence of the target virus is difficult to ascertain. The cutoff should be manually adjusted to ensure that specimens with high CORT values are not incorrectly assigned SARS-CoV-2 detected due to background noise. In Portugal, judges ruled that a single positive PCR test cannot be used as an effective diagnosis of infection for the purpose of quarantining someone. Did the WHO issue the notice because of concern about legal action? When only a small proportion of people being tested have the virus, the operational false positive rate becomes important. Think how many people might have had to quarantine unnecessarily, missing work, or an urgent medical exam, or to the detriment of their mental health, for example. For some people, being told they were positive with a disease that has been described, the greatest threat in peacetime, could have been very stressful. Lockdowns and restrictions were based on the number of cases. And absolute totals of cases were used to scare people into complying with the rules. The CORT in the UK appears to be set at 45. As Professor Carl Heenahan said when he gave evidence in the House of Commons to the Science and Technology Committee on 17 September 2020, a cycle threshold above 35 generally involves people who are not infectious, yet NHS England documentation that has not been updated since January runs cycle thresholds to 45 that identify people who are not infectious. Heenahan was asked about introducing random testing, mass testing, as Professor Alan McNally of Birmingham University had recommended. This was his answer. In effect, you are saying that random tests will pick up people, potentially with dead virus. Remember, it picks up an RNA strand that is 220 nucleotides long. That degrades much slower than the actual infection when you have it on board. After 8 days, we cannot isolate live virus, but for up to 90 days you can isolate the RNA fragments and pick them up when you test. So, if you randomly go into schools, you might as well shut them down right now. It is not a process that I have recognized in 20 years' experience of being a clinician, as a GP, or a process that is aligned with evidence-based medicine. If we are to go down those routes, we have to think of the wider context of what harms they introduce, what the social consequences are and what the plan is. The UK government rolled out mass testing and proposed mass testing in schools. Although, when mass testing was introduced in schools in March 2021, the less sensitive lateral flow test was used. Positive tests, cases and patients. This is an example of scary semantics rather than dodgy data. People who tested positive were called cases, and in one case I noted the word patient was used. Both case and patient imply illness and symptoms, whereas many of the positive test results were asymptomatic or post-infectious. A medical diagnosis of case would normally involve symptoms plus a positive test, not a test on its own. Death statistics. I was flung into my armchair death expert status by the whiplash of an epidemic and lockdown. The next chapter explains how changes to the death registration process mean there are now serious problems with counting the dead.